great to be here with the GAP MASLD MASH community network that is sponsored by Madrigal. We're really excited to be able to bring you this opportunity to try and really, there's lots of these meetings. If you've seen, you can pick and choose which ones you do. This one is going to be on lifestyle management, but there are all the different topics within the whole MASH MASLD bucket. And we hope that you'll register for as many as you want, pick the ones you do, the whole series if you want, do multiples of the same, because we're really hoping that we're recognizing in the world of trying to build knowledge in MASLD and MASH, a lot of it is peer-to-peer. And so this opportunity came forward with some sponsorship by Madrigal to try and find that how do we do that well? There's all these different resources out there for education, for CE, for just educational knowledge. What do we do to make something fun and appealing and easy and accessible for our working APPs that want to expand their knowledge, and especially for the fact that those people who've been doing it for a while to share back with the people who are new to the field. And also, so we're giving back and forth questions this way, tips this way, mentorship potentially happening. So we hope that you'll join as many of these meetings as you have time to, and just listen in the background during your lunch. Feel free to turn on the audio if you are not able, if you're able to, or take, ask questions, raise your hand. So with that disclaimer, you should probably know who I am. I'm Elizabeth Goacher. I'm a physician assistant at Duke University. I've been here for 24 years in the hepatology space, 28 years altogether as a PA, which means I'm old. Yes, it's true. And that also interesting now in my world of hepatology to circle back to my primary care beginnings, because really MASLD and MASH really does start at that front end. We're going to talk about some you probably already know, and we'll talk more about how the components of the metabolic syndrome that are the part of the diagnostic tree for MASLD really are primary care. We're kind of a universal, we're treating multiple things with one effort, for instance, like with lifestyle modification. So I find it really interesting. Here I am, 24 years into this field, and I'm really circling back to my beginnings in primary care. This is your QR code for recording. We hope you'll do that so that we can show that we see who will be touched and make sure that we're following up with any questions, and also to get you back to other meetings and keep you up to date on all the exciting things that GAP is doing. So what does lifestyle management mean? What does it mean, right? I mean, lifestyle, I went to Oxford, OE, and said, what does it mean? It's the way in which a person or group lives, or a typical way of life, individual, group, or culture. Now, of course, in lifestyle modification and healthcare, we're looking at what does it mean for health and what's lifestyle modification or lifestyle interventions. But we also need to think about that might be impacted by the culture in which a person lives. And when you think lifestyle, you might think diet, exercise. I think about activity levels. I think about the foods you put in your mouth, the places you go. If I was Garfield, I might think about this as being my primary lifestyle tool. Garfield, for those of you who are old enough, loves lasagna. So what do we think about lifestyle modifications? We do think about food. We're going to talk a little bit about that, and not to make assumptions that lifestyle always means lasagna changing from our lives, because who wants to live without lasagna? But anyway, we're going to start with a case. So it's always fun to try and frame these in terms of things that fit. This is a very common scenario, I think, for all of us that are working in this space, either in primary care or in MASLD, right? So a 65-year-old person who has identified as a Hispanic race with a BMI of 29, which is abnormal. He has type 2 diabetes, he has high blood pressure, he has hyperlipidemia. And when we see him in the office, we track back that this guy has had upper limit of normal ALT at least for the past several years. So either normal or 2 times the upper limit of normal, never exceedingly high, but up to 2 times the upper limit of normal repeatedly. He's got an A1C of 7.2%. And because he has the abdominal adiposity, but he doesn't have any exam findings that are suspicious for portal hypertension. So by that we mean no spider angiomata, no caput medusa, no abdominal varices in the skin that we can see, no jaundice, no overt stigmata of advanced disease. We can feel comfortable about that. And pretty easily we diagnose him with metabolic dysfunction, right? Because he's got fat, he's got metabolic dysfunction, we have metabolic liver disease. And what do we do with that now? We go through our pathway, we make sure we're looking at, do we have advanced fibrosis or not? We start with our FIB-4, which is our tool. It screens as indeterminate, it follows as indeterminate, which tells us if we follow this rubric that I won't go into too much detail here, but it looks like we need to get a second non-invasive test. We are lucky that we have FibroScan available, so we're able to get that. And we find that that's a 6.7. So we have a gentleman who's 65, who has an elevated BMI with diabetes, high cholesterol, and hypertension, who has MASLD without advanced fibrosis. And so he falls into a person whose recommendation is lifestyle modification. And what is again, I'll circle back. So and I tell my patients the same thing, congratulations, you don't have advanced fibrosis. Well, what do I do? What's the treatment? The same treatment that you should already be doing for everything that already have. What do you do for hypertension, hyperlipidemia, and diabetes and extra body weight? You work on those factors. And we do know that this is a spectrum. You can go from steatosis and then the itis starts to happen, and that's when the fibrosis starts to happen. Majority of people are in this benign steatosis or very early fibrosis, steatohepatitis. 70% of people never develop advanced fibrosis. So we want to try and track the people who do have advanced fibrosis and focus in that group with more aggressive therapies, but everybody on the spectrum to try and prevent progression, looking at lifestyle modifications. And we do know it's not just about what we think of as typical lifestyle things. There's more to it. There's particular, perhaps there's a genetic influence of how we respond to the different impacts in our lives, and those are being worked out, not for prime time now, but just to keep in mind, sometimes when a person says it doesn't matter what I do, nothing changes, maybe they're right, because in their genes, and we need to tailor that. We know that there's particular impacts of different types of components of the diet. We know that saturated fats are really, worse. They cause inflammation and turn on the reactive oxygen species and really add to that. We know that fructose is especially heinous when it comes to fatty liver disease because of de novo lipogenesis and then decreased oxidation and more oxidative stress. So if there's one thing you can do in lifestyle, it's get rid of the fructose, right? We just know there's multiple factors. And so when we're talking about lifestyle modification, I want to make sure that we're remembering that we're treating the big picture too. And how do we do that? And how important it is in MASLD. We can't in liver disease exist in a world where we only treat liver specific drugs or targeted medical therapy. We have to start thinking about how we help patients. The majority of our MASLD patients who have lifestyle modification needs, all MASLD patients do, but the majority of patients, setting some concrete recommendations back to primary care or in our office if we're following on how we help them. So I feel like I've been rambling on. I'm making sure, is there anything in the chat that I need to look at, Denise? Or not Denise.
Nope, not yet. I don't see anything.
Okay, cool. I'll keep rambling. Then, so when we think about management at MASH, we do in lifestyle modification in particular, we know it's not just about what we're putting in and what we're burning out, but in particular, looking at the balance of those things. So we need to balance nutrient in that are helpful and good and are less likely to develop steatosis, and also energy out and making sure that we're find that balance. And that will help us target the central obesity, which is the major promoter of insulin resistance and pro-inflammatory signaling. So if we're getting that right energy balance and addressing central obesity is where our biggest payoff is going to be. Well, how do we do that? Well, let's talk about food. So let's start with the beginning. Everybody eats. What do we do? And we're talking with our patients about how to alter, or do they need to improve their lifestyle? I think that's important. We also remember not all of our patients need to make further lifestyle modifications or in all areas. Some of our patients are already doing some really good things with their diet. They already know and are doing what they should be doing. But always starting neutral and saying, tell me about your diet and talk to me about how what you eat and how you eat. And in this particular situation, we encounter in this person's background, they're Cuban in their background, and he describes what he describes as a Cuban diet: rice, beans, pork, beef, corn, plantains. So all heavy fats and triglycerides, high carbs. So things that we need to really, those are opportunities. So it makes sense that we have it's an opportunity to intervene, right? And how do we talk about diet? And what do we say? Do we talk about the components? Do we talk about the timing? We talk about how much and the volume they eat. And then trying to figure out ways where there's opportunities. Sometimes there's no opportunities, but if there are, what would they be? And sometimes small things are all we need to do. Sometimes it's not changing the components of the diet that a person is eating, but looking at the amount of what they're eating. So And I also think it's important to put that in the whole picture. You know, lifestyle is not just about the foods and exercise, but about our routines, because our routines, our sleep-wake cycle, when we nap, if we nap, what's our rest and activity levels like at baseline is going to impact how we make some counseling recommendations. Are they already an exerciser? What have they done? Did they used to do aerobics when they were younger, or they used to jog when they were younger, but now they're doing yoga, or they're doing something less active, or basketball in their past, right? And are they doing enough of it to really burn cardio? What about their housing structure, how they live? Do they work full time? Are they home most of the time? Do they work from home? These are all things that knowing all these components of a person's lifestyle helps better address where there's opportunity to make change. And again, always don't assume that somebody needs it. Maybe they're already doing it. We want to ask open-ended questions about, tell me about your diet. Tell me about what you eat. Tell me about your activity patterns. Tell me about your typical day, so that we can hear from them in their own words what it is. To frame things and do you exercise is really a hard question, right? Because everybody says, sure. And then what they say is, yeah, I walk all the time. I really active job. That's so then you have to backtrack to say, well, wait, that's not exercise. If you start from tell me about your day, and then you focus on, okay, that's great. You walk 7,000 steps a day. That is great for keeping active. Are there times when you actually get your heart rate up, and kind of build on the conversation so you're not turning people into having to say, ooh, no, I don't do that. Don't put them in a corner where they're having to say what I don't do. Say what they do so that you can build on that. So we want to think about the dietary change. We want to think about the exercise. What in particular, what's the big deal? We do know this is important because there's the earliest data, some of the oldest data we have about what impacts MASH and MASLD and reduces progression is weight loss. We know that when people in Dr. Harrison's study way back, long time ago, I can't even right now remember exactly when, but in some of the MASLD studies early on, it was clear that when people lost 10% body weight from baseline, they were able to mobilize fat and move their fibrosis down. So we know that weight loss can have an impact. The thing I also think about when I tell a person is 10% weight loss, make sure that we're giving that person a target number. 10% weight loss is not something people are going to do the math on. You need to look at the person's weight. They weigh 220 pounds. You want them to lose 10%. You need to tell them, I'd like you to lose, your goal could be 22 pounds. So that I think that's important because I see so many of my own notes, even 5 to 10% weight loss recommended. Let's be concrete. As referenced before, just to circle back, we know that some things may impact us. So time coming forward, we may be customizing our recommendations for diet and exercise. Some evidence in these different polymorphisms has shown that the response to exercise with some of these polymorphisms differs in terms of triglyceride response. We don't have more to share now, but just to think about, there are other factors maybe beyond just exercising that we need to think about or may customize. We know that the Mediterranean diet has been recommended and has been helpful and proven to be helpful in reducing fat in response. It's mostly looked at in cardiovascular disease, but looking at fat mobilization and fat in hepatic fat mobilization in patients on Mediterranean diet for other reasons did improve, and which is where the strength, what's where you see the recommendation is from the Mediterranean diet, and all the guidelines is out of that. The healthy diet, a Western diet being less healthy and trying to move away from that. Western diet typically higher in concentrated sweets, sugars, packaged foods, processed foods. Basically, I always say if it's in a bag, if it's in a bag, you can get it through a drive-through or a jar, or something in the freezer section. All of those things are bad for you. We know sedentary behavior and altering that can make a difference, and we know particularly aerobic and resistance exercise can help. We looked at the difference for fatty liver disease when it comes to different types of exercise. It was shown that there's been a study that showed that HIIT or high intensity interval training was not effective at mobilizing fat store. However, resistance and aerobic activity both were really good and showed improvement in mobilizing fat. So it's not the HIIT, not that you're going to tell me not to do HIIT, right? Because that's fine, it's exercise. But if you're going to get a focus on where to put your exercise, resistance or aerobic exercise would be your recommendation. Any exercise is more than what's not happening. So what works for that person? But just thinking about the difference between the types of exercise, if you could mobilize people into resistance or aerobics, either one is fine to make a choice. So that means if you're talking with a person about what exercise can they do, and they have a pool that their next door neighbor has, getting in the pool and doing water walking is just as good as going to the gym and doing weightlifting, as long as they're burning the intensity at the same time. It's about the caloric balance. You can get the same caloric burn from one or the other. When you think about MASLD-friendly diet, what's the MASLD-friendly diet? The healthy diet, right? What is a healthy diet? Well, that may come from where your background, what is healthy according to your background, and trying to be particular and teasing that out in that person's dietary inventory. The Mediterranean diet is particularly supported by all the different guidelines as being helpful because it has shown to improve hepatic steatosis, particularly mainly by secondary effect in these other cardiovascular studies. But I think a small group of studies showing it also in just fatty liver disease. It promotes ketogenesis, and definitely helps with caloric restriction, which that's still, whatever the diet is that your patient's following, caloric restriction to achieve weight loss is a central tenet. I also wanted to know what a Mediterranean diet was, so I put that in here because you hear it thrown out there all around. The Mediterranean diet is what it sounds like to some degree. I think I'll admit I overgeneralized. To me, Mediterranean diet means lots of hummus and couscous and all those grains and legumes. And actually, that is a part of it, but only limited amounts. I thought maybe it was hummus every day, or feta cheese every day, but no. Mediterranean diet is described as 2 to 3 servings of fruits and vegetables every day, with limited use throughout the week of whole grains. When you focus on it, to focus on whole grains, bulgur, barley, farro, at least 3 ounces a day, without going too much over 3 ounces each day max. Then limiting your meat, and when you do eat meat, which you should eat sometimes during the week, to focus on seafood or fish and avoid red meats, and in particular avoid sugar and saturated fats. So it's not as, I think it's easy to think about lean proteins, but it's important to focus in terms of the proteins, specifically seafood or fish, and then focusing on the unsaturated fats from plants and avoiding polyunsaturated fats. So how do we help Albert with his lifestyle modification? So we've been thinking about asking the right questions, framing them the way that he's going to be able to give us honest answers. I put in the slide, I went ahead and X'd out, I put this, originally the slide was given to me and I did alter it slightly. When we think about he returns and he's back to follow up and he's got same labs, no improvement in his liver enzymes, but the framer of the slide wrote, he admits that he has not begun any exercise regimen. And I really, it gave me a pause. Let's remember that, what does admit mean? Admit means I'm saying I'm guilty. Guilty is a negative connotator, right? Let's talk about he reports. Let's reframe that. Even in our notes, I think that's helpful in our brain. We're not admitting guilt. We are reporting that we didn't change, because that honesty and that truthful relationship helps us to try and move forward. So making sure that we use the right language to talk to people about things that are hard to do. And then what do we do further to help with change? What could we do in this situation? What were some opportunities? This is one of those things that, if people had time to chime in, I'm happy to hear them comment. I know people are busy, but where are things that we could dig in for Albert? Looking at, could he just, if he eats a typical Cuban diet, because that's the food that's prepared for him potentially, maybe he's not his own cook, he's eating the food that's prepared for him, does he eat less of it? Can he focus more on the meat and less on the carbs? Even if it's pork or beef, reducing your carbohydrate load and staying further away from the plantains and the corn and the carbs, maybe that's one way to go. You got more protein, less carbs. It's good to hear, you applaud him for the fact that it doesn't have a lot of processed foods, right? So he's eating mostly natural, fresher foods, the helpful, always give people props where they can. And looking at, they can shift, is there a way to shift towards more chicken, less beef or pork, and seeing if there's any protein substitutes that would be palatable to the person, either Albert himself if he's preparing his food or whoever is preparing his food. So
Yeah, I think, oh,
go ahead, Denise. Great. Jump in.
yeah, I think that's kind of, I also encourage them, especially like with this patient you described. I mean, we're talking about there's quite a bit you may want to change, right? And so I think that that's always really overwhelming for them because, I try to talk to them about like, I'm talking about a lifestyle you need to be doing, because we can't go back to what we were, right? Because we'll be right back to where we are. And so I typically talk to them, but then there's one thing and focus on that for a couple of weeks. So like, okay, create your work on so maybe focus on let's eliminate that first.
Yeah.
And then we can focus on adding in some other challenge for you, because I always, try to speak to them. It's like, it's not easy. And like, especially.
Oh, did we lose Denise?
Oop,
She was
I
coming.
think
She was,
there
she
she
was
is.
coming. She back?
Can you hear me?
Yes.
There you are.
Oh, yeah, we've been having some internet issues at my office. So I think sometimes it kicks me off. But so I try to focus on like, okay, well, maybe try and, how much soda are you drinking a day? And then I talk about, okay, well, let's try and challenge ourselves to drink maybe before you eat your meal, an 8-ounce glass of water. And then maybe once you've got those 3 glasses of water down, maybe try drinking a glass of water mid-morning, midday. So like I try to break it apart for them because I think the diet is the hardest part for them to change.
Yeah, those are really great points. You bring up, small incremental change is important. Follow up is important, regroup, set a goal for what's reasonable. Don't set a goal, like you said, this if we eliminated all the things in this person's life that needed all at once, that's not going to happen, right? So small
Right.
incremental
Yeah,
change.
never.
It's overwhelming. And then
Yeah.
also
Yeah.
they get lost, the brain just starts going spinning and you can't even focus. So one thing, it's okay. I think, and sometimes we feel, I love that you bring that up, Denise, because I think sometimes as healthcare providers who are fixers, right? We want things to, that's what we do. We fit the pieces of puzzle together
Yeah.
to make everything perfect. This is a slow process. We are in a marathon, not a sprint. And I tell that to patients all the time. I think maybe I need to hear it as well, that this will be a slow incremental process.
I like that too. And
Yep.
I think saying a lot of times we're talking about a lot of things in this first visit, especially in hepatology, I'm sure, and in primary care too. And so don't bite off too more than you can chew and don't overwhelm the patient. So give attainable goals before the next visit that you can try to work towards, and also just assess the barriers. Definitely applaud him. He's cut out soda, and that's tough to do. That's a big change that needs to be applauded. But what are your what is your barrier to exercise or physical activity, and how can we help you overcome those?
Yeah, good thoughts. I appreciate both of those. Those are really, really helpful. And thinking about circling back, both in setting the goal and being concrete about the goal, because that also then gives you as a healthcare provider a place to jump off at the next visit. Say, okay, here was the goal. How are we doing on the goal? Both of us visit, just doing that blanket, you need to lose weight and exercise. But be concrete in your recommendations and in your documentation. So it'll help you. So you can do it too. I think this is a two-way street here. So I appreciate those comments. Those are great. We are pretty much at time. I didn't, or have a few minutes if there's any other conversations or thoughts that people want to add.
Yeah, so when it comes to like physical exercise, like especially this person who hasn't done any sort of exercise regimen, I think a few years ago the JAPA Journal had an article on fatty liver, and they had recommended that there seemed to be a benefit in walking at least 200 minutes a week. So typically, I don't know if you had read that article or not, but that's something I typically recommend for my patients. I was like, if you're not doing any sort of exercise now, maybe start with that as, a goal. Not obviously do I expect them to do it right then. I was like, maybe just start with like 15 minutes of walking every other day and build there with a goal to that. Is there anything similar that do you encourage walking or some sort
Yeah.
of program like that?
we encourage walking to get to the place where they can do more vigorous exercise. If they ever,
Exactly.
it's a great place to start. The goal needs to be that what we know for energy caloric balance, that it is that, the 150 to 200, 150 to 200 minutes of moderate, or 75 to 125 minutes of intense, but you got to start somewhere. And that's the other thing.
Right.
Anything helps above the nothing that you're doing now.
Sure.
Anything makes a difference. You're going to be doing more than you're doing zero here. Anything that burns calories. So that means, yeah, those things you guys probably, I bet both of you say this one, park in the far side of the parking lot.
Mm-hmm.
I do not give out handicap placards. That's
Nope.
only for oxygen dependent people. I'll do it for that. But everybody else,
Right.
no. In fact, don't want you to have a handicap sticker. I want you to have motivation to walk across the parking lot. But things like any opportunity to change makes a difference. So absolutely. Not specific to the walking, only as a bridge though, because you still need to get to that, if you can, get to that moderate to vigorous exercise long-term goal. I have to admit, I've got just a handful of patients that actually ever make it to that, straight up, which is what I have to remind myself, though. I do have a handful that made it. I do have a handful that made it. We had training with a few years ago. We were lucky to have a clinical trial that embedded an addiction therapist in our group, and she taught us. The focus was on alcohol and Hep C. It was years ago, and it was about having the trial was to see if there was an impact to having on-site substance abuse care, and what she did though was teach us about change management. And one of the things she said that her mentor taught her in substance abuse management is don't give up. You never know, even though it feels like every time you're trying to make a change for people and supporting them through these stages of change, it doesn't happen, but you never know when the next time you say something is going to be the time that somebody's changed. So I hold on to that all the time with all my different change management patients who need whatever the issue: diet, exercise, alcohol, heroin, opioids, whatever we need to change. You never know when the next time you say something is going to be the time that somebody changes.
Hey,
All right.
Elizabeth, I put a question in the chat just because I think it's a question I get a lot, and maybe it would be helpful for the primary care community and other GI APPs. But patients come in all the time asking me, well, what about intermittent fasting? I've been doing my own research, or the ketogenic diet. What would you recommend?
Yeah. So my, the ketogenic diet is going to be helpful for weight loss most of the time for the people that can stick with it. Does it improve fat, steatosis in particular? I have to admit, I'm not up to speed on that. I know intermittent fasting doesn't seem to make a difference, but it can make a difference in weight loss. I think anything that my typical advice is any diet that gets you, moving more or helps you lose calories is going to be the diet. Do you know the data? Do you put the chat in the question so you can answer it too? Because if you can, I would love that. You're on mute if you're trying to answer. My understanding though is that no one particular diet of ketogenic versus intermittent fasting has been proven to be better than the other.
Sorry, did you want me to state the question again?
No, I want you to tell me what you know, if you know the answer.
Oh, yeah. I mean, I usually tell patients kind of very similar. If it's going to help with weight loss and calorie reduction, then go for it. But the diet that has been extensively studied is the Mediterranean diet. So that's the one I can recommend and talk most about. But it's a question I get a lot. So I was just curious how you approach that question.
Because your answer, that's exactly, because that's the point, right? The point of all of this lifestyle modification that we're discussing is how do we help people mobilize fat, which will help their diabetes and help their weight as well, and their high blood pressure and their lipids. And the Mediterranean diet is the only one that's been shown to specifically help be associated with hepatic fat store reduction. But any weight loss is going to help with fat store reduction. It's like,
right.
Yeah, I haven't done I know this, there may be data out there that says the same thing and I'm not familiar with it, but the concept holds. You're losing weight, you're going to help all things. All right, my audience friends, it's been great to have you join us. I really appreciate the participation and the conversation. Make sure that you use the QR code to record your attendance for this meeting if you have not already. And also, this QR code is for all the other resources that are available at GAP MASH Community Network. And I already did the Q&A, but I'll remind, especially Denise, we're going to be up at the GAP National Meeting in, we're going to be in Red Rocks this year, not like last year, like we were nearby, but we hope,
Right.
hope to see your crowd out in Las Vegas.